All right, good morning, everyone. It is such a treat to get to introduce our Grand Round speaker, Dr. Chiadi Ndumele, today. Chiadi and I were actually medical school classmates, and I was calculating, Chiadi, shockingly, I think I've known you more years of my life than I have not known you at this point. But that is my benefit. Dr. Ndumele did his medical school at HMS. He did his residency at the Brigham, where he also was chief medical resident. He then did cardiology fellowship at Johns Hopkins University, where he currently is an associate professor of medicine and epidemiology. Chiadi is an incredible preventive cardiologist. He directs the cardiometabolic and obesity research unit at Hopkins, as well as the heart failure prevention program. He runs an NIH and AHA-funded lab, really looking at obesity-related cardiovascular disease and how we can use population and clinical-based studies to better understand. I think what makes Chiadi really special is not only is he incredibly smart, but he can also bring people together and really inspire them. And I think that's what makes him really one of the most extraordinary leaders in our field currently. He put those skills to use by bringing together a bunch of cardiologists, nephrologists, and endocrinologists recently. He actually chaired or co-chaired the AHA's enormous initiative on cardiovascular kidney-metabolic health in the past 2 years. So we're really excited you're here today, Dr. Ndumele, to talk to us about that. Thank you.
Thank you so much. It's really quite an honor to be here. My nickname for Jen is Gold Standard. So take that with what as you will. And it's wonderful to see so many friends, old friends, new friends. So thank you for the privilege of being here. So I will be speaking about my perspective on kind of the emerging challenges and priorities for cardiovascular kidney metabolic health. And no disclosures here. And my goal is to first, I'll do a brief kind of description of the rationale and the definitions for this cardiovascular kidney metabolic health construct, but a broader focus on kind of the approaches to thinking about risk in this context, and then even more so on the priorities. So where the key future priorities from my perspective are for optimally addressing the clinical needs of this very large population. So I'll start with a case to kind of hopefully ground things. So this is a 54-year-old woman. It's a very standard case that we often see. History of obesity, hypertension, and diabetes, coming into established care after the death of a family member, so being activated by that. Self-care and health lifestyle, she really describes as being quite challenging. She's a single mother, she's working full and part-time jobs, and actually a ton of stress and smokes cigarettes to alleviate that. She's on amlodipine and hydrochlorothiazide for blood pressure, metformin for her diabetes, and her examination shows a blood pressure of 144/92, a BMI of 38, elevated waist circumference, normal JBP, clear lungs, and S4, a protuberant abdomen, and also trace edema on examination. Labs are really notable for fairly elevated A1C at 9.2, EGFR that is in the stage 3 range, and a UACR that's also fairly elevated at a 1 of 53, and then elevated cholesterol, LDL, and total cholesterol, as well as triglycerides and a low HDL. So really, as you see this case, we think about this as the kind of case we see routinely in cardiology, preventive cardiology clinic. And I think the 3 questions are, first of all, what's contributing to her cardiovascular risk? What are the things that we need to be considering? How do we best classify and then quantify her cardiovascular risk? And then really, of course, what are going to be our best strategies for optimizing her cardiovascular kidney metabolic health? And the things that really stand out to start are obviously that we have multiple interconnected comorbidities that are kind of very apparent within her presentation. She obviously also has a fairly high burden of adverse social determinants of health that are impacting her health behaviors, engagement with the healthcare system, and also some other behaviors like smoking. She has obviously some uncontrolled risk factors. Chronic kidney disease didn't make its way into her diagnosis list because it's really not recognized that she has high risk chronic kidney disease. And there's really multiple opportunities that are pretty apparent here to optimize her cardiovascular kidney metabolic health, both from a social standpoint, from a lifestyle support standpoint, and obviously from a pharmacotherapy standpoint. So as Jen mentioned, and Jen was a part of, as I'll say again, is that we had a presidential advisory and scientific statement on this concept of cardiovascular Kidney Metabolic Health that came out in fall of 2023. So why has this been such an area of focus? Well, the real rationale for this is multifold. Number one, we know there's a clear interplay, very close interconnection among these metabolic risk factors, things like obesity, diabetes, the broader construct of metabolic syndrome with chronic kidney disease in the cardiovascular system. But even more importantly, that's very key. That's been the case for some time. It's taking on so much more importance because we've had a shift in actually the phenotype of heart disease risk in the population. More and more obesity, diabetes, and CKD. Kazi has done beautiful forecasting about where things are headed from a national standpoint, and earlier presentations with cardiovascular disease. And we know that this is now multi-system compromise as a result of this, but also the most important thing is premature mortality that's primarily due to cardiovascular disease. This is also a major driver of disparities in cardiovascular rates and outcomes because it's seen disproportionately in the population. So a lot of urgency, but also a lot of opportunity because now our scientific understanding is substantially increased and we have a lot of new therapies that are impacting metabolic outcomes, kidney outcomes, and cardiovascular outcomes, and sometimes doing all three at the same time. So this is an illustration of this change in the phenotype of cardiovascular risk. So this is a hierarchical clustering analysis and looking at kind of what the landscape looked like in 1990 versus closer to the 2020s. And what you can see here, so this is kind of saying, in an exercise, what's the predominant phenotype? What's the major driver of cardiovascular risk for these individuals? The purple and the blue are hypertension and hypercholesterolemia. So that's kind of outsized, but what you can see over time is that the proportion of individuals for whom that is the predominant phenotype of their risk has steadily decreased over time. In contrast, you see obesity and you see CKD, and you can see in the orange and the light blue, those have substantially increased over time with a stable incidence of fairly severe prevalence of severe hyperglycemia. So we're seeing more and more of obesity and CKD and hyperglycemia and less of just hypertension and hypercholesterolemia alone as the cause of this. I lost my screen, so I have to look up here. Oh, here we go. It came back. Yeah, it's just going to play games with me, which is fun. Obesity and diabetes epidemics are very clear to us. We see the CDC maps everywhere. We see wherever obesity goes, diabetes follows, and they're national epidemics. And, these are interrelated through kind of inflammation, insulin resistance. A lot of this is about ectopic fat deposition in the visceral cavity, the liver, skeletal muscle, lots of things being released that basically impair insulin sensitivity, cause impaired glucose tolerance, and over time, you get pancreatic beta cell dysfunction that results in hyperglycemia. This is actually even more than that, of course, because we have a greater interconnection. So we start with excess and dysfunctional adipose tissue as the core of most of what we're seeing for CKM syndrome. We have this ectopic fat deposition that potentiates that. We have these central processes of inflammation, oxidative stress, insulin resistance, and vascular dysfunction, and it precipitates metabolic risk factors, precipitates chronic kidney disease, potentiates heart-kidney interactions, and leads to various forms of cardiovascular disease. And this just illustrates the importance of these interconnections and really underlies the definition for CKM syndrome, which is simply, and we spent a lot of time sitting in a room for this, Jen and I, a health disorder that's due to connections among heart disease, kidney disease, diabetes, and obesity that leads to poor health outcomes. Now, the confluence that we see with this has the principal consequence of premature mortality. And we see that for the individual components. So severe obesity, about an 8 to 10 year survival reduction. Diabetes, about a 13 to 14 year survival reduction. And the earlier onset of diabetes has a greater survival reduction. And then stage 4 CKD, about a 20 year survival reduction. But in real life, we don't usually see these independently, but we usually see these more overlapping. And this confluence has a synergistic impact on mortality risk. So 10-year mortality rates in the US for diabetes, around 8%, CKD about 11.5%. But when you put the two together, the diabetes and CKD, it supercharges that mortality risk. The sum is more than the parts, more than a 30% overall mortality risk. And this substantial impact on mortality has actually made a very significant dent in what we're seeing in terms of our cardiovascular mortality rates in the broader population. So most of you know that, every few years, the AHA sets goals historically and says, we're going to hit this new number for mortality reduction and this new number for mortality reduction. And over 5 decades, we've had continuous declines. That has now stopped. So in the last decade, we've had a full plateau, and the most recent data suggests an uptick. And this is widely believed to be related to the rise of obesity, diabetes, and CKD. So this is obviously a lot of public health urgency. And as a result, the AHA put together this science advisory group. And I wanted to highlight my good friend Jen Ho here, but also highlight the fact that there was a really nice multidisciplinary group that really came together to try to address this multi-system challenge. And I think that's the kind of collaboration that's going to be necessary, both clinically, scientifically, and in terms of these kind of consortia to make a dent in this challenge. The goal was to move from a clinical compendium and action plan, which is the first step, the presidential advisory, the scientific statements. There was a consensus conference to bring folks together and make sure we had perspectives from different societies. And now the focus is moving towards adoption and implementation. And I'll come back to this at the end. So I'm going to spend most of my time really focusing on the question of where are the actual emerging priorities for optimizing cardiovascular kidney metabolic health? What are the challenges and what are the related opportunities? So here are the 5 areas that I would kind of describe as where I think are the top priorities moving forward for optimizing cardiovascular kidney metabolic health. The first is that we are clearly in a situation where we need to have earlier detection of risk. We know that that's going to lead to enhanced prevention of cardiac and kidney disease, and is going to be a key imperative as part of this initiative. We know that we need to move beyond just what we're seeing in the office setting and think more about the broader social context, because it is driving so much of what we're seeing, and it's necessary to consider that broader social context to optimize lifestyle and cardiometabolic health. We also recognize that a key challenge for individuals with multi-system disease is clear fragmentation of care. And we have to think through systems that are going to actually help in terms of reducing this fragmentation and improving more collaborative opportunities for people who have multi-system disease. There's also historically underaddressed conditions, and I think obesity and chronic kidney disease are ones that have really not gotten much attention from a cardiovascular community standpoint, but really need to be a big focus if we're going to make a dent here. And then I think more broadly, a greater focus on multi-system and holistic approaches to care. So I'm going to go through each of these in a stepwise fashion. And at the end, hopefully we'll have a little bit more time to talk and see if there's any additional perspectives in this regard. So this is a quote from Machiavelli. I don't quote him very often, but at the end of the day, he was here talking about political systems, and he used health as a metaphor for that. But I think this is actually quite apt for how we should think about cardiovascular kidney metabolic health. He says, at the beginning, a disease is easy to cure, but it's difficult to diagnose. But as time passes, having not been recognized or treated at the outset, it becomes easy to diagnose, but quite difficult to cure. And we know that once we have that real significant multi-system derangement, it's quite easy to diagnose. Those individuals are coming in, but very, very difficult to cure. And I credit Matt Budoff for actually highlighting this quote in one of his earlier talks. So key priority number 1 is a focus on early detection and early prevention. And that's really the rationale for the concept of cardiovascular kidney metabolic syndrome staging. The staging construct is meant to do a few things. Number 1, to reflect the fact that we have this typical progressive pathophysiology, starting from that excess and dysfunctional adiposity due to the emergence of metabolic risk factors, and then the subclinical and clinical disease. But also, because it is accompanied by a screening paradigm, it actually also improves the identification of a lot of under-recognized clinical conditions that are obviously initially asymptomatic, but do confer substantial increased long-term clinical risk. Additionally, as we're going to be navigating this population, we need to think about how we're going to prioritize the intensification of therapies. And as you move along this spectrum, we have higher degrees of absolute risk, both for cardiovascular disease and other adverse outcomes that necessitate more intensified therapies. And I want to emphasize, you could do this in a variety of different ways, and something we wrestled with as a group. You could, talk about the risk for they could talk about frailty, you could talk about cognitive decline, you could talk about a lot of things, but we focus on cardiovascular disease as our main focus along that axis of risk, because that's the primary cause of premature mortality in these individuals. And we also focus on kidney failure, but even in those with chronic kidney disease, cardiovascular disease is the primary cause of mortality. Now, importantly, each of these steps represents a window for preventive intervention that can actually support preventing progression to later cardiovascular kidney metabolic syndrome stages. And that's a key goal, but an additional key goal is to also support the concept of CKM stage regression. And 15, 20 years ago, it would have been like, how much of that can we actually achieve? But our tools for doing this actually, obviously, is substantially improved in recent years. So with marked lifestyle change and multiple modalities to support weight loss, we can see substantial CKM stage regression as well. So this is the stages. I imagine many of you have seen this staging figure previously, especially the folks who are working on their grants right now. And the CKM stages really progress as I've described. So starting with stage 0, with no risk factors of focus on primordial prevention, to stage 1 with that excess and or dysfunctional adipose tissue. That's really the precursor to most of what we see in terms of metabolic risk factors and chronic kidney disease. Moving towards then the development of subclinical cardiovascular disease or risk equivalence. So we have risk equivalence of very high risk CKD, which I'll describe more later, or high predicted risk using the prevent risk calculator. And then moving towards clinical cardiovascular disease. And the goal here again is to prevent progression along this spectrum, to intensify therapies in the later stages, and also to promote regression along this spectrum here as well. In terms of thinking about progression along this spectrum of CKM syndrome, it's always hard to understand why are some individuals progressing super rapidly across this and some individuals having a relatively slow progression temporally across this spectrum. And one of the things that we recognize is that risk enhancing factors are actually quite key to conceptualizing individuals who are at greater risk for progressing along this spectrum and also progressing to end organ injury, cardiovascular disease, kidney failure. So things like chronic inflammatory conditions, a higher burden of adverse social determinants of health, some high risk demographics, which is a very interesting discussion because it's unclear what the mechanism is for some of these populations like people of South Asian ancestry, but we do know there's a very substantial risk. And how much is social, how much is biological is a still ongoing question, but we know it's a group that needs to be highlighted. Mental health and sleep disorders, sex-specific risk-enhancing factors that are quite prevalent, like adverse pregnancy outcomes, elevated inflammatory markers, and then family history of kidney failure and diabetes. All of these are things that actually can help to support a more personalized discussion with patients when we're thinking about how we're going to approach things therapeutically, both from a lifestyle and pharmacologic standpoint. I think Dr. Khan was here recently, Sadia, and talked about the prevent risk model. And this really resulted from this initiative that there was a need for an updated prediction approach because we weren't really thinking about these new challenges that were represented by cardiovascular kidney metabolic syndrome. So first, we know that heart failure is a major outcome in this population. So we do have an ASCVD calculator, but also a heart failure calculator, and then also a composite of the two of those together. There's actually a reasonable, very strong correlation between those two. Anyhow, to capture global cardiovascular risk. The age range is expanded to earlier, starting at age 30, recognizing we're seeing earlier and earlier presentations with cardiovascular disease. Several CKM syndrome components like kidney function, BMI in the context of heart failure, A1C added to the prediction model to really start to incorporate these as how we're thinking about prediction. And then race was not included in this model. That's a nice discussion to have, but the concern here is that we want to make sure we're capturing these social determinants. Those were included in the model, and we do see really good calibration, so about a 1-to-1 in terms of observed to predicted across various demographic groups. So we're not seeing any decrement in our predictive accuracy by race, despite that not being in the model. And I just want to highlight the fact that this is really complementary to what I described for staging. So a quantitative risk prediction approach is going to be very complementary to this qualitative staging approach. So stage 3 already talked about the fact that the high risk is a risk equivalent, so high predicted risk, but also in those individuals in stage 1 and 2. And stage 2 in particular is a very large population. So considering their predicted risk will actually help to identify individuals with a higher net benefit from some of these preventive therapies. And this is going to be a helpful tool as we start to think about these pharmacotherapies beyond statins in this population at risk for cardiovascular disease and kidney failure. Now, the group here did a wonderful analysis in looking at the implications of this using the current thresholds with PREVENT. And basically, the thing that's first found on top here is that what we know is that because PREVENT is correcting the overestimation of risk that we saw with the pooled cohort equations. Pooled cohort equations basically overestimated by about a factor of 2. We've now seen a shift to a much lower risk estimates, almost half of what we were seeing with the pooled cohort equations. So if we kept the exact same thresholds that were used for statins, like 7.5, what we see is a dramatic reduction in individuals who will be eligible for these therapies. And they show this for, this is Kazi and Rishi and lots of other folks here. Bobby showed this for cardiovascular disease, statins, and also for hypertensive medications. So this really does speak to the fact that we need to think about, and the guidelines are considering now, what is the appropriate threshold when we're thinking about prevent to apply to risk prediction models. But it's likely the case that the current existing thresholds will not necessarily be able to apply to prevent. The second big priority here is thinking about social determinants of health and thinking more holistically about CKM syndrome care in that regard. And we know we have a lot of race ethnic disparities in the burden of CKM syndrome. We know that's largely driven by social determinants of health. And why that's the case is because many different aspects of the lived experience of individuals with CKM syndrome are very much affected by the social context. And we also know that all these therapeutic approaches that I'll talk about at the end, they're great, but the access is more limited in those individuals who actually have the greatest overarching need and are more marginalized with high social needs. So how do I conceptualize thinking about social determinants? It's really across the full spectrum. So first of all, they have a direct impact on what the health behaviors are. So direct impact on how we eat, how we sleep, how we play, how we exercise, all kinds of aspects of our lived health behaviors. They also impact the likelihood of CKM risk factors developing, but when those develop, the likelihood of them being identified in a timely fashion is very different among those with more adverse social determinants of health. We know that once those develop, the self-care that goes along with that, as well as the engagement with the healthcare system, is also adversely impacted by more adverse social determinants of health. And then we also know that through those mechanisms and through maybe more direct physiologic mechanisms, we see a very significant difference or an increased likelihood of CKM syndrome and complications in those with more adverse social determinants of health. So we describe this socio-ecological framework for thinking about this construct, where we think about the multi-level social determinants of health, both at the societal level, community level, interpersonal level, and our health behaviors, all of which are very closely interrelated that impact our overarching outcomes in this population. And we do have different degrees of biological predisposition, our genetics, our epigenetics, the microbiome, other aspects of our hormones. Many things impact our individual predisposition, but it needs to be nested within or considered within this broader socio-ecological framework. So thinking about SDOH in all aspects of CKM syndrome assessments and management is going to be a key part of equity in our approach to thinking about CKM syndrome care. So how do we think about that in the care model? Well, number one, we want to do systematic screening for social determinants of health using validated tools. The prevent prediction model now includes an SDOH measure within there. Those SDOH screening assessments need to be integrated into our clinical care workflow, and then we need individuals on the care team who can actually react to those, community health workers and care navigators, leveraging community resources and community programs to support individuals with more adverse social determinants of health. It's not going to be solely enough just to focus on prescribing medications. We need to actually think about the broader social context if we want to make a dent in the equity for CKM syndrome care. Key priority number 3 is reducing fragmented care. So if you have individuals who have multiple conditions, multi-system compromise, they're typically going to be seeing multiple different providers. So primary care, of course, but also cardiologists, endocrinologists, nephrologists, other individuals who are supportive within the care team. But what that can lead to is obviously, number one, difficulties with just navigation, including especially those individuals with more adverse social determinants of health, but also silos where things will fall through the cracks. Whose responsibility is it to think about the obesity or the CKD? And these things will fall through the cracks sometimes. And even worse, it's actually sometimes competing recommendations where you're hearing one thing from the nephrologist, another thing from the cardiologist, another thing, and the patient doesn't even know who to listen to. So this is a big challenge in this context and a need to move from that fragmented approach to a more patient-centered approach where there's some alignment across specialties and also shared responsibility with regards to think about what the patient is seeing rather than our individual silos of care, but more of a holistic approach to that and a focus on coordinated care and also the social context. So that's the vision from this standpoint. So one of the questions here is that there's a lot to do. There's a lot of systems to think about, a lot of therapies to think about. And what's the benefit of coordinated care models, which is something that we put forward? Well, what we've seen so far is that if you think about CKM care coordination, in the context of multi-system disease, we've seen that it's actually been fairly effective, whether it's done virtually or in person, and whether we use nurses or pharmacists, and actually sometimes even other adjunctive members of the care team, but really the strongest evidence for nurses and pharmacists. And it really impacts the holistic care approach. So this is a trial by Neha Pajadipati, one of our former, well, sorry, we're not the Brigham, apologies, former Brigham intern, who basically, a resident, who basically did a recent randomized cluster trial in JAMA that showed with a multidisciplinary team and an implementation specialist, who's essentially a CKM coordinator, they saw about a 4-fold higher likelihood of being placed on the relevant CKM therapies, but then also they had a secondary clinical outcome and showed about a 20% reduction in the secondary outcome of all-cause mortality, hospitalization for cardiovascular events, or urgent revascularization. So the evidence is starting to emerge, but we do know that this is not something we just drop in physicians' labs and say, okay, figure this out about how to coordinate multi-system care. So we put forth 2 complementary interdisciplinary care models. One is a value-based care model, where it's kind of a focus more on remote interdisciplinary care, where we see confluent CKM risk factors, a confluence of CKD and diabetes, which is a particularly high risk, or of course, existing high-risk subclinical or clinical cardiovascular disease, with a focus on interdisciplinary care support from primary care, as well as subspecialist nursing, pharmacy, and a CKM coordinator, with the goal of partnering with PCPs and supporting patients along the journey to optimizing their cardiovascular kidney metabolic care and health, as well as value-based care models, which is more referrals for high-risk patients to nephrology, endocrinology, and cardiology, which could be right-sized to the subspecialty density in a given area. And there's more focus on supporting patient navigation across subspecialists. And an ability to move to a telemedicine approach more as needed, or to rely more on a volume-based care approach is needed, but the idea of these are being complementary to support interdisciplinary care approaches for patients with multi-system disease. All right, key priority number 4 is a greater attention to the historically underaddressed risk factors. And the 2 that I want to highlight are obesity and chronic kidney disease. So I've mentioned here that obesity is at the root of so much of CKM syndrome, but the reality is that we only effectively address it in a minority of clinical encounters. And there's a lot of different reasons for this. So we don't get trained in how to take care of obesity. If you look at our board examinations, I think the percentage of questions around obesity historically has been like less than 1 or 2%. It's very, very not a part of our curriculum. But there's also a substantial amount of weight bias and stigma, not just in society, but also within clinical environments. Interestingly, there's a very strong correlation between the training of individuals with regards to understanding weight, the medicine, obesity medicine, and the degrees of weight bias and stigma. The more you understand about it, the much less we see in terms of stigma, in terms of our approach. We also obviously have a lot of challenges in terms of reimbursements, and we also, for therapies, for lifestyle modification, and then of course, limited time and resources in the way our infrastructure is currently set up, because there's a need for ongoing care. But because there's an increasing array of tools and an increasing recognition of how important this is in terms of the ground floor of CKM syndrome, there's growing interest in making this a focus. So there's a lot of more people who are thinking about getting trained in this regard. Chronic kidney disease is another one that's historically quite underaddressed. And the data, like the classic data say 90% of individuals who have that diagnosis are actually unaware of the diagnosis. And what's important is that we now know that a lot of the therapies that prevent progression of CKD also reduce cardiovascular disease risk. But the earlier we detect it and the earlier we initiate therapy, we have more optimal outcomes from a preventive standpoint. So 3 days ago, the Lancet Diabetes and Endocrinology came out with an obesity commission, where they basically described obesity as a driver of multi-system compromise. It's been all over the news. And they basically use this construct of preclinical obesity and clinical obesity. And the things that I want to highlight here, they focus on the idea that number 1, we need to move beyond just a focus on BMI alone and think about other anthropometric measures. And number 2, that we need to think about obesity as a disease when we start seeing the clinical manifestations of that. So they wanted to avoid over-labeling the whole population with obesity as having a disease, but focus on the fact that when those actual complications occur, and the complications, of course, are quite multi-system, all the way from CNS to musculoskeletal to obviously all the cardiovascular kidney metabolic things that we're talking about as well. I just want to highlight that this concept of preclinical obesity correlates pretty well with the idea of stage 1 CKM syndrome. So individuals who have that overweight and obesity, we do include overweight because of the increased cardiovascular risk we see there. But then the clinical obesity is really so much of what comes next in terms of stage 2 to 4. But the point is, there's a growing push towards this idea that this needs to be a central focus as part of our overall care models. Why do we care about obesity? Well, caring about obesity is not just important in stage 1, it's important across the full spectrum of CKM syndrome. First of all, it's a key component of how we think about preventing progression along those stages. You can certainly treat hypertension when it arises. You can certainly treat, give medicines for diabetes. But if you want to actually prevent that progression, the root cause that's driving it, that underlying adiposity, obesity is a key thing to focus on. But it's also a really key point because it can also be the primary mechanism for promoting regression across the CKM stages. So we actually looked at this in the bariatric surgery population recently and just talked about this at AHA. So if you look at bariatric surgery, just over about a year or so, you see regression in all the CKM syndrome components, as you might expect: hypertension, hypertriglyceridemia, hyperglycemia, chronic kidney disease. And you see that many individuals are regressing, going less down from stage 3, down from stage 2, and you start to see more emergence of stage 1, just obesity or overweight alone, and also the emergence of people who are stage 0, whereas just basically not even just normal weight in the absence of metabolic risk factors. And there's a dose response, so that basically, if you look at this in a spline model, so the degree of weight loss and the odds of CKM syndrome regression, each 10% greater weight loss, we see about a 2-fold higher likelihood of CKM stage regression. So weight loss is going to be important for both progression and also regression. But the important piece here is that the way we approach it is very important. Currently, because we're not well trained and because there's so much stigma, we do a lot of judgmental approaches in our weight loss discussion. There's a lot of stigmatizing language that we're not even aware that we're using. But what my colleague Kim Gudzune showed is that in those individuals we have a non-judgmental weight loss discussion, there's about a 4-fold higher likelihood of, relative to those who we don't even have a discussion with, of clinically significant weight loss. That's where we're going to see the best activation from a patient standpoint. So how do we do that? Well, the Stop Obesity Alliance has actually developed a very nice toolkit that kind of walks individuals through the appropriate approach to addressing obesity in clinical encounters with a 6 A's approach, starting from ask, to assess, to advise, to agree, to assist, to arrange, starting with the simple question of whether now is a good time to discuss how your weight and health may be affecting each other and how we can work together on it. The point is, this is a need from a training standpoint, and this is an important window, the first step to really having a successful approach to thinking about addressing obesity with patients. So this is a very key part of the toolkit for individuals for CKM syndrome. We also know chronic kidney disease is a major risk factor. So this is a clear evidence that lower eGFR is associated with major cardiovascular events, cardiovascular death, and all-cause mortality. But eGFR, we now know, is not sufficient. So we need to take into account both your estimated glomerular filtration rate, which is here, as well as your albumin, which is here, to fully characterize the degree of chronic kidney disease. And those individuals who are in the yellow are kind of moderate risk. Those individuals who are in the orangish are high risk, and those individuals who are the pink and red here are very high risk. And when I talk about very high risk, it's not high risk for just kidney failure. It's also very high risk for multiple forms of cardiovascular disease events, as well as for all-cause mortality. And it's important to recognize there's a lot of people who have moderately decreased eGFR, and if you don't take into account your albuminuria, you will miss the degree of actual risk those individuals have. So we need to use those in a complementary fashion to actually understand risk. And I just want to say that we were actually talking about this last night at dinner. So chronic kidney disease, particularly diabetic kidney disease, is likely going to be our next major frontier in the realm of cardiovascular prevention. We now have, it's called the 4 pillars, which I don't love that term, but we have at least 4 therapies now that I'll go over it a little bit later that are very effective in type 2 diabetes and chronic kidney disease to improve both renal and cardiac outcomes. The RAS inhibition, SGLT2 inhibitors, nonsteroidal mineralocorticoid receptor antagonists, and GLP-1 receptor agonists. And these are all very powerful for improving outcomes. And what we have now, I think, is a really nice algebra where we have a high prevalence of unrecognized CKD. CKD itself is associated with a very high cardiovascular disease risk. We have a lot of these now risk-reducing therapies. So much potential. a lot of unrealized potential for improving population cardiovascular health. So I think that if nothing else, making this a bigger focus is going to be a really big way to actually change the tide from a population standpoint. So one more area I want to prioritize is an emphasis on multi-system and holistic care. And I think the key takeaway here is that it's really not going to be sufficient any longer to think about just an individual risk factors for your patients for really optimally preventing heart and kidney disease. Those days where just somebody comes in and just a hypercholesterolemia issue, it's just rare that that's going to be the case anymore. And if you see people with cardiovascular disease, it's increasingly the case that we need to think about the fact there's a multi-system underlying etiology, even if it hasn't been fully recognized. So we need to think about achieving control of these multiple interrelated risk factors in CKM syndrome. And there's two real approaches. One is the use of lifestyle modification, which is hard to do, but effective when it's sustained with targeted pharmacotherapy as needed to achieve goals. And the second approach is the use of these CKM therapies that have multi-system benefits. And I think in concert, the two of those are actually going to be quite effective. So first, let's talk about the concept of lifestyle modification plus pharmacotherapy. So the trial I love to focus on here is Steno-2. And the Steno-2 trial was about 160 patients, a very CKM population. Overweight, obesity, type 2 diabetes, albuminuria. And there was a question of usual care, so just giving them the usual things we did, versus a very significant lifestyle change support, as well as then pharmacotherapy as needed to achieve glycemic goals, lipid goals, and blood pressure goals. So what do we see? Over the course of about 10 years, there was about a 46% reduction in mortality and about a 60% reduction in cardiovascular disease events. And that's really important because if you know anything about the diabetes literature, you know that glycemic control alone, just as a standalone, we see almost no benefit for macrovascular outcomes, some benefit for microvascular outcomes like retinopathy, but nothing for macrovascular disease. So it's really necessary to address these underlying metabolic determinants, and this approach could be very effective for doing so. Now, of course, we have a growing array of CKM therapies, as we call them now, that have benefits on the cardiovascular, kidney, and metabolic systems. And I'll go through this one by one. So one is the SGLT2 inhibitors. So these started as obviously diabetes agents, but turn out to have fairly modest glycemic benefits. Most of the time we see an A1C reductions about 0.5%, sometimes 1%, but an outsized impact on major adverse cardiovascular events and cardiovascular disease mortality is shown nicely here in this meta-analysis at about 15 to 20%, depending on the trial, reductions in those, a substantial reduction, particularly in heart failure hospitalizations, and a significant decrease, particularly in kidney events. We see about a 40% reduction in adverse kidney events. So these agents, multi-system benefits, C, K, and M, unexpectedly, but much more than just diabetes agents. Finerenone, the non-steroidal mineralocorticoid receptor antagonist, we see also having substantial benefits. So in the context of diabetic kidney disease, we see a reduction in adverse kidney events among those individuals. We also see a reduced we saw initially in the Figaro, the Fidelity and analysis, we saw a reduction in cardiovascular event rates, mostly heart failure, that seemed to be driven largely by protection against kidney function decline. And then most recently, Scott Solomon's group at the Brigham led the Fine Arts trial, so it's not preliminary anymore, that actually showed the substantial benefits of finerenone in those with heart failure with preserved ejection fraction and mildly reduced ejection fraction for improving outcomes. So that'll probably become a part of our armamentarium for heart failure, particularly with preserved ejection fraction moving forward. But I'm going to spend a little bit more time on GLP-1 receptor agonists because I think that these are really going to be central to not only care moving forward, but they have such marked multi-system effects. So first, we know that, and by GLP-1 receptor agonists, I'm talking about the broader class of incretin analogs, so not just GLP-1, but also GLP-GIP, GLP-GIP glucagon. There's a whole forum, there's a whole list of these coming down the pike. So first, we're seeing with the newer generations, marked weight loss, so 15 to 20% weight loss. We also see improvements in glycemic control and metabolic risk factors, and then reductions in major adverse cardiovascular events, MI, stroke, and cardiovascular disease mortality. And a lot of that started in the diabetes population. Importantly, whereas for most of our lifestyle modification, when we lose weight, we see it come back pretty quickly, a weight kind of recidivism. When you stay on the medications, we see that there's actually a pretty sustained reduction in weight. That being said, Kazi and others have worked on the idea of discontinuation, and when there's a discontinuation, we see these effects reverse quite quickly. Now, a big paradigm change was with the SELECT trial, because the SELECT trial ended up enrolling people with obesity and overweight, but no diabetes, but also ASCVD, and still saw a 20% reduction in major adverse cardiovascular events. And notably, they started to see a separation in the curves for major adverse cardiovascular events pretty early on, in around 4 months or so, well before we see substantial weight loss, which made us say, hey, is there a vascular benefit to this that's above and beyond what we see for weight loss? Well, that's also supported by this trial. This is the Harmony Outcomes trial of the GLP-1 receptor albiglutide that doesn't have a very significant impact on weight. So you can see here, the weight reduction is not significant here at all. That being said, we still see about a 22% reduction in composite cardiovascular outcomes despite the lack of weight loss. So it speaks to the fact that there's a weight-related component, but then also a weight-independent component that are both important to the effects of these agents. Now, this has actually now become more and more target in heart failure preserved ejection fraction, Jen's area, where we basically are now seeing in the STEP-HFpEF trial that semaglutide resulted in several important things: improvement in quality of life using the KCCQ score and 6-minute walk distance, reductions in inflammatory markers, as you might expect, but importantly, reductions in NT-proBNP, as well as some echocardiographic improvements. The NT-proBNP is notable because if you've ever seen, so individuals with obesity tend to have a natriuretic peptide deficiency. It tends to be suppressed. And most weight loss studies, we see NT-proBNP go up, even in the context of bariatric surgery. So this was actually a very interesting circumstance, seeing the NT-proBNP go down in the context of substantial weight loss, which seemed to say, there's something else going on here that's maybe direct myocardial benefits above and beyond the weight loss benefits. And that was further verified by the SUMMIT trial led by Milton Packer of individuals with obesity and heart failure with preserved ejection fraction. Again, saw the improvement in the KCCQ score, but then also a 38% reduction in cardiovascular death or worsening heart failure events in this population. And in a sub-study that had cardiac MRI, favorable cardiac remodeling in terms of in this patients based on related to tirzepatide. So this really speaks to the fact that we're seeing a direct benefit on adverse myocardial remodeling, as well as all the other metabolic effects and likely other vascular effects of these agents as well. So multi-system, multiple axes of cardiovascular benefit. Another very, very key trial is FLOW. So the FLOW trial of GLP-1 receptor agonists in patients with diabetes and CKD, and importantly, this was not all the way up to the 2.4 range that we're seeing for like trials like SELECT, only 1 milligram, so really relatively moderate dose. But there was a reduction in adverse kidney events, a reduction in major adverse cardiovascular events, a reduction in cardiovascular disease mortality, and even a reduction in all-cause mortality. And the outcomes were so favorable that actually the trial got ended early because of evidence of clear benefit, and the similar relative risk reduction seen across the spectrum of baseline risk. So really, this group is another group. We don't fully understand the mechanisms by which we see a CKD benefit related to GLP-1 receptor agonists. A lot of hypotheses out there, but we don't fully understand. But the larger point is that we're seeing a substantial improvement in that population as well. So when we think about multimorbidity and CKM syndrome, you can look at this in a couple different ways. So the incretin analogs really are obviously affecting excess and dysfunctional adipose tissue, the inflammation and oxidative stress and insulin resistance, the metabolic risk factors, the CKD as I just showed, and they also have both indirect and direct effects on the cardiovascular system. So they're affecting multiple different aspects of this pathophysiology. But here's the challenge. The epidemiology of CKM syndrome is that most people in this spectrum, 90% of adults in CKM stages are in CKM stages 1 through 4 with work by Muthu's group over at the Brigham. But we know that a lot of these people have some indication, whether it's excess weight or diabetes, with or without CKD, heart failure, or ASCVD for these therapies. But we're obviously not going to give them to everybody. Kazi has already shown, for example, that we'd bankrupt our system by doing so. I think Bobby as well. So how do we prioritize utilization of these powerful therapies that are impacting multiple axes of this risk? Well, I think there's 2 potential approaches to consider for prioritizing these pharmacotherapies. So one is to think about, where are we seeing the most multimorbidity? Where are we seeing multi-system compromise that we can conceptually may get significant bang for our buck? But then also, where are we seeing high cardiovascular risk, where we might expect to see a greater absolute risk reduction. So in terms of multimorbidity, there's clear populations of patients with complement disease that are standing out from clinical trials where we're seeing substantial benefit. Obesity with HFpEF, obesity with diabetes and atherosclerotic cardiovascular disease. Certainly the patients with diabetes and CKD, like for Flo, particularly high and very high risk CKD. And we need more evidence, but it's likely that we're going to see more multi-system benefit and some substantial improvements with incretin pharmacotherapy. But then I think the other way to think about this as well is using predicted risk. So if you think about predicted risk, one of the purpose of this is to say, if you have a therapy that has a certain relative risk reduction, in those individuals who have a higher baseline risk, we're going to see a greater absolute risk reduction. Same relative risk, but because their baseline risk is higher. So you can see this individual here who's green, a relatively modest improvement in absolute risk compared to this individual, same relative risk of the benefit of the therapy, but greater absolute risk reduction because of the higher baseline risk. And this then results in a lower number needed to treat, which Kazi, correct me if I'm wrong, that usually relates to more cost effectiveness of these therapies. Yes. So at the end of the day, the one question is, do we need to focus on that? Well, this is actually a nice example from the TIMI group. David Berg from their group and Mark Sabatine led this study looking at people with diabetes. So we often think about monolithically, but if you take this here and say, what's your risk based on predicted risk? Is it low, intermediate, high, or very high? And those who are low predicted risk within the population of diabetes, you have an absolute risk reduction of 0.3% and a number needed to treat of 300 to achieve a cardiovascular benefit, compared to those who are very high with an absolute risk reduction of 2.7% and a number needed to treat of 36 to achieve a cardiovascular benefit. So thinking about the predicted risk and the absolute risk is probably going to be a helpful way to think about where we're going to see the biggest bang for our buck. Coronary calcification is another way of thinking about absolute risk as well. So this was done, modeling studies like they've done for statins and ASCVD have been done for GLP-1s. And you can see here the number needed to treat for GLP-1 in a modeling exercise for those individuals who have no CAC, who have CAC 1 to 100, or who have CAC greater than 100. And again, a stepwise improvement in the number needed to treat as you get to more and more subclinical atherosclerosis. So I think it's pretty easy in the context of thinking about this when these two overlap, when you have substantial multimorbidity and you have high predicted risk. I think the more challenging question is, what if you have high 10-year cardiovascular risk, but you don't have substantial multimorbidity? So that's usually going to be older adults who have a more isolated CKM risk factors, but just by virtue of age have higher predicted risk, or persons who have mostly non-CKM risk factors like smoking or pure hypercholesterolemia. How do we manage that? Do we think about this the same way because they're high overall absolute risk, or do we say, maybe that's not going to make as much sense? On the other hand, what if you have substantial multimorbidity, but you don't have high 10-year risk, like younger adults who have a lot of adverse CKM risk profiles and have a very high 30-year risk maybe, but their 10-year risk is pretty modest because they're not going to have a heart attack in the next 10 years. How do we deal with that? Do we think about, hey, we're going to get this intermediate benefit, but from a healthcare system, from a cost standpoint, can we actually support that? So these are, I think, the questions we're going to have to actually contend with and really study moving forward in terms of how we're going to address this Venn diagram of risk in the population with CKM syndrome. The other thing to conceptualize is going to be combination therapy. So modeling exercise like this one from Brendan Nguyen suggests that if you have SGLT2 inhibitors plus GLP-1 receptor agonists plus finerenone, do all this stuff together, we're going to see more and more benefit. There's a lot of assumptions in this, but the larger point is that we're going to see benefit. And that may be the case, but then we have to think about the cost and the polypharmacy and everything else. So probably this combination therapy question needs to be balanced against the costs and the challenges related to pharmacotherapy, polypharmacy. And this is probably something that will be prioritized for those who are higher risk and also have that multi-morbidity. So we have an algorithm for CKM syndrome management, and it focuses on the things I've talked about: interdisciplinary care, addressing SDOH, addressing obesity through multiple modalities. This is for stage 1 to 3. Thinking about CKM risk factors and addressing those and controlling those. For cardioprotective antihyperglycemic agents, we talk about a comorbidity-based approach to selecting which one you're going to select, an SGLT2 or GLP-1 receptor agonist, and then preventing CKD progression is a key target, and thinking about more intensive therapy and more combination therapy in those who have higher baseline absolute risk. And in stage 4, where we have already, with existing cardiovascular disease, higher risk, there's going to be an intensified focus by definition on interdisciplinary care and supporting social determinants of health addressing. Obesity and CVD, as per the SELECT trial, we're going to be thinking about the lifestyle support as well as the pharmacotherapeutic approach in that population, addressing and controlling CKM risk factors. Pretty much everybody with diabetes and CVD is going to need to be on a cardioprotective antihyperglycemic agent, and preventing CKD progression as possible with these various powerful agents. So that's kind of the broad approach. And the next step now is moving from this clinical compendium to the consensus, but now moving to adoption and implementation in the population. So we really highlight a framework, 8 pillars for optimizing cardiovascular kidney metabolic health in the population. It includes considering social determinants, access to pharmacotherapies, addressing the key research gaps, like in this SFRN that's coming up, interdisciplinary care models, CKM education, enhancing our approaches to obesity management, an implementation approach within and across health centers, and then, of course, stopping the pipeline of individuals who are coming in by supporting healthy lifestyle in communities. And I'll just highlight 2. One is clearly going to be access to pharmacotherapies. That's clearly one of our biggest log jams here. And there's a lot of work on multiple levels, thinking about both the people who can help facilitate access in the health system, but also changes from a policy level to ensure more access. Then also, we're going to really need to think more about the cost and the value of these therapies. And there's going to be a lot of stakeholders that need to come together to make sure we can right size what we're doing from that standpoint. So that's a key focus. Also, the AHA has announced a 4-year implementation project for CKM Health across 150 health centers over 4 years. So it's basically going to be focusing on using this framework and supporting a move towards this kind of holistic care model, and designating centers of excellence for CKM Health, as well as also certification programs, doing this domestically initially, but with an eye towards a broader global focus for this in the countries where AHA is currently engaged. And again, the goal is to move from siloed care to thinking about this holistic framework to care, and not just thinking about it for your patient or my patient or one person's patient, but thinking about this from a system standpoint, so that we're actually more systematically considering the whole patient, the coordinated care approaches, and then also the broader social context. So this is the vision moving forward for the implementation of CKM care. So going back to our case of the 54-year-old woman with a history of obesity and hypertension and diabetes who was coming to establish care, there's a few things that stand out. As we assess her risk, her 10-year cardiovascular risk by PREVENT is actually 31%. So if 20 is the threshold for high risk, then she, by definition of that, makes her way into CKM stage 3 as a risk equivalent. It was also a clear, even without doing a screen, evidence of social needs here, and you probably can uncover more. So this is a scenario where there's likely a lot of ways we can both address the social determinants and support that with community health workers and social workers. She has multi-system challenges with multiple systems involved. And this is a scenario where for this single mother, we're gonna have to think about how are we helping her navigate all these multiple providers, navigate all these various conditions. And I think interdisciplinary care team support in a way that's less cumbersome for the patients can be very important. In terms of specific clinical approaches, so in the setting of uncontrolled hypertension and albuminuria, RAS inhibition is going to be much more preferred for those from that standpoint by guidelines. So noticing her CKD and albuminuria should be important for that aspect of her management. And clearly, you want to think about a cardioprotective antihyperglycemic agent here. So they have an A1C that's high, multiple things that are abnormal in terms of both kidney disease, as well as blood pressure, as well as severe obesity. So probably a GLP-1 receptor agonist is where you'd want to start here to basically address the roots of this multi-system derangements that we're seeing among this individual. And I haven't talked about statins because LDL is not as well correlated with all this metabolic risk, but we know that we want to target our intensive lipid lowering therapy, not just individuals with diabetes, but also to where we see the highest global risk. So this is going to be an area where we want to think about statin therapy for addressing that as well in this scenario. So in summary, the concept of CKM health really reflects the fact that we have this close interplay among metabolic risk factors, chronic kidney disease, and the cardiovascular system. It's highly prevalent, CKM stage 1 through 4 in 90% of the population, but disproportionately prevalent in those with more adverse social determinants of health, and is a key predictor of premature mortality. And really, because we have multi-system morbidity, there's a need for more holistic care approaches. So optimal approaches to care moving forward are going to reflect both assessing that risk, identifying risk early using a staging and the risk estimation in a complementary fashion, collectively addressing the interrelated risk factors that are at the core of CKM syndrome, considering the broader social context as well as what we're seeing in the office, supporting approaches to coordinated care, and that's going to really happen at the systems level, and then emphasizing a therapeutic approaches that have multi-system benefits. So thank you very much, and I'm happy to take the questions for a few minutes. Thank you. Please. Yeah. Yep. Yep. So I think that. Yeah. No, it's good. I think. Oh yeah. The question is basically, why are we moving from the generic steroidal MRAs to the non-steroidal MRAs? And I think it's a very, very good question. So one piece is, number one, I think, to your first point, I think we know where we have good evidence for the steroidal MRAs, first of all. We have great evidence for heart failure with reduced ejection fraction. We also have great evidence for blood pressure, so for resistant hypertension in particular, and we know we see benefit from that standpoint. The non-steroidal MRAs, I think now, so TopCat was a very challenging study in terms of actually knowing what to do with that data. This is a much more definitive study from that standpoint, but I think the key question is whether or not it's really not the case that we're going to see a similar benefit with the steroidal MRAs. Nobody's going to do that trial. So what's going to actually have to happen is a pragmatic approach to assessing that in the population. And I think it's a key question of whether we're going to see the benefit. And frankly, I think with pragmatic studies, we're probably going to see maybe not equivalency, but some significant benefit of both kinds of agents from that standpoint. So I think that's probably going to be the case. You will probably have a little bit less in the way of side effects with the non-steroidal MRAs overall. And that's going to be one of their biggest selling points. But I would say that I don't disagree that there is actually, first of all, we need the data to support that it's actually going to be beneficial. So right now we have the data in these other areas. And I think there's a call, frankly, for a more pragmatic approach to assessing, do we have some degree of equivalency between those two approaches? I think, especially since we're worried about costs. And this happens as obviously every time. So the GLP-1s, there's no comparison, right? That's what's going to be the case. But when you have the agents where you may have another option, I think it's worth seeing whether or not there's some benefit there. So I think that there's actually a real need to do that kind of work. Hey, Rishi. Yeah.
It's hard not to see that stagnation. My question is, how about your optimism for testing in terms of stemming, given the water right now? And I think that first, the incoming information.
Yeah.
A lot of people are two, I'm thinking about how the ACA basically lipid net.
Yep.
DC screen, how that's being challenged. It just feels like we're fighting an uphill battle.
Yeah.
And I think the framework you laid out is so good because it's multi-interdisciplinary. There are these just broader things.
So to briefly repeat, so Rishi's saying, why don't we just give up? So here's what I would say. I think so I can't speak to the whole what's going to happen from a political standpoint, but what I will say is that the reason why this is a moment is because so many things are aligned, right? So we do have a ridiculous need with regards to where we're going from a health standpoint. The cost associated with doing nothing is actually going to be quite substantial, and it's rising dramatically. So right now, it's about 1.8 trillion for obesity-related costs. It'll grow substantially, and you've shown this in your work as well. And we have a lot of avenues from a therapeutic standpoint that we know could be beneficial. Sometimes it's going to be the more expensive therapies, but even just attention early to some other less costly things could make a really big dent from a population level. So I think what I always find interesting with regards to the politics is when the rhetoric meets the reality. And, you know, maybe they'll like say, hey, we're going to take all these things away and we're going to stop all these things. But the reality is, first of all, it's hard to take things away like that, first of all, especially in terms of some of the screening pieces and some of the other things that go along with that. So you rescind part of the law, you got to rescind a lot more of the law. So that's one thing. I do think, though, it's going to be a very interesting question of how we engage, not just in terms of the defensive part, but the offensive part of this. So I think that I really am very interested in how the government is going to be engaged from a price negotiation standpoint for these agents. So you may know that if you go to, we talked about this last night, if you go to Mexico or go to Brazil or somewhere else, these agents cost a very different amounts than they cost here in the US. And they kind of arbitrarily say, hey, this is where we're going to make our money and these are the costs. So I do think, first of all, when PCSK9 inhibitors came out, there was a very big focus on the cost effectiveness of these agents. And then basically it was like, look, this is not going to make any sense at your current list prices. And this is where we see some actual reasonableness from us, that standpoint. I think that those kind of analyses are actually going to be really helpful to say, that's from a policymaking standpoint, and to guide the government in terms of where we're negotiating. I know there's already some negotiations in place from that standpoint. So I think that there are real challenges, but I think that the synergy in terms of opportunities, and I think that the reality of removing some of these things is going to cause so much mayhem that I suspect that lawmakers are actually, that's beyond me, but I suspect that something's going to go slow. I also will say that there's a lot of advocacy from multiple avenues here to try to make sure that we actually move this ball forward.
Silver line policy, silver line. We're just
Well, I was waiting for that, so that's exciting. That's exciting. Yeah, I think that's it has to be, especially now that they, for Medicare Part D, have covered for the indications in SELECT, where, by the way, in SELECT, if you use I think they said to prevent one CV death in SELECT, is it $1 million per the current estimate, around there or so? So like, clearly there's a need to dramatically come down on those costs generally. So yes, this is, I think, an important frontier.
in terms of the, oh, sorry, go ahead. No.
Yes. Yeah, it's a good question. So first, I'll be quick so we can answer other questions. I'll say, number one, from a nutrition standpoint, two things are important are going to be access, and it's going to be support from that standpoint. So including people, nutritionists on the team and making that a key part of care is important. In terms of one nutritional approach, nobody is currently endorsing just one approach. There's a big discussion in the nutrition community. I'd say we have a lot of data around the Mediterranean syndrome kind of general construct, and then in the context of hypertension, a DASH syndrome construct. But in general, you know, the heart healthy kind of themes will generally apply. But I think the support and the access are going to be really key from that standpoint. And then the second question was about the yeah, no, I think actually the good thing, the reason I brought up Mediterranean is because we're going to, the long term, the Mediterranean is because we're actually going to see actually benefits in all those things, the inflammation and pieces like that. In terms of the long term, I think that's a very key question. The other key questions are compounded medications. Other key questions are discontinuations. A lot of people are getting therapies for like 6 months or 12 months. Is that beneficial, or is it better to never have had it at all? Lots of key questions. The AHA has just announced they're starting an obesity registry that's going to be starting with a key focus on this new landscape of obesity therapy. The focus specifically on understanding long-term outcomes, both with regards to adverse effects in body composition and frailty and functional status, as well as these real-world challenges and the use of these compounded therapies. So I think that's a key question, and one that I think is going to be hopefully addressed in the coming years.
Obviously important. There's another aspect of primary prevention that I think is missed by these approaches. Obesity-directed PCPs, and that is 25 years ago, teams published 53% the initial manifestation of cardiac disease.
Yeah.
Those people, that's really challenging.
Yeah.
To identify people with care of obesity specifically being identified as a risk, that type of event. But it's something that
Yeah, so I think that's a good question. So first of all, I would say that most of that sudden cardiac death was probably not just arrhythmogenic phenomena, or more so related to underlying cardiovascular disease, that was their manifestation. So I think actually addressing a lot of these root causes that actually cause a lot of the subclinical changes and will result sometimes that is actually going to be a key part of that. To your point though, obesity is actually associated with a higher risk of sudden cardiac death independently from a non-ischemic mechanism. But I think the primary reason for that was that people's first presentation was with coronary disease, obstructive coronary disease as a cause of fatal disease. So I think this approach of identifying these asymptomatic risk factors earlier in a more timely fashion and having everybody be on the same page of those, I think is going to be helpful from that standpoint as well.
I like the concept of
Yeah, good question. So I hear that about this as there's a woman who apologized to me the other day because she told me apparently she accosted me somewhere about the liver and why we're not talking more about the liver. I was like, take it easy. So you know, the liver is actually quite important from a few different standpoints. Number one, MASLD, as it's now caused, is commonly thought of as the hepatic manifestation of metabolic syndrome or CKM syndrome. So it's quite clearly related. We see a potentiation of all the inflammation and some hepatic insulin resistance, and it probably is a lot of the times when we see hypertriglyceridemia, we're probably seeing MASLD as part of that. It didn't make its way into the staging construct because in the staging construct, everything that's in there has a clear evidence for a causal relationship with cardiovascular disease. It's closely associated with cardiovascular disease, and MASLD is the leading cause of liver transplantation right now in the US. So we do incorporate the concept of screening for liver disease. And frankly, a lot of the things that we're talking about, including the GLP-1 receptor agonists, actually very much reduce and reverse a lot of this liver disease. So we're going to see those liver benefits. We're also going to see cognitive decline benefits. We're going to see sleep apnea benefits. There's a lot of other systems that are related, but the reason why it's not in the staging is specifically because of the lack of a clear evidence for a causal relationship that we reverse cardiovascular disease just by addressing the liver. But I think it's closely related to the whole thing, and I think we need to pay attention to it as part of CKM syndrome care. So in the staging framework, screening for that is a key part of this.
We're at the top of the hour. Thank you so much, Chiadi.
Thank you.
That was quite a treat.
Thank you very much.
For the conversation.
Thank you. Thank you so much, everybody.